acute vaginitis. The vagina in the adult is one of the most resistant parts of the genital tract, as it is covered with pavement epithelium. And further, through the trauma occasioned by intercourse and childbirth, it becomes to a certain degree toughened and not easily infected. But the vaginal membrane readily becomes involved in young girls, whose mucosa is delicate, or in newly married women, whose mucosa is not hardened by congestion and trauma. When the gonorrheal infection is hyperacute, the entire genital tract may be involved in one continuous infection, and in these cases, the vagina is not exempt. Acute vaginitis may be primary, but is usually secondary to a gonorrheal cervicitis or endometritis. Symptoms. The patient complains of burning and a sense of weight in the vagina, and as the vaginitis is usually accompanied by urethritis and cervicitis, the symptoms of these conditions are usually added. Examination with a speculum in the knee-chest position, observing the precautions, page 142, shows the vaginal mucosa to be the seat of an acute inflammatory process. The entire vaginal wall may be intensely congested, hot, swollen, and bleeding readily, or it may be bathed in a copious, purulent discharge. Erosions with bleeding edges may be found, usually in the posterior fornix or in other portions of the vagina. The gonococcus can, as a rule, be readily found in the discharge. Diagnosis. Acute non-gonorrheal traumatic vaginitis is encountered in the newly married and among those who use strong medicated douches as a precautionary measure. These forms of vaginitis, puzzling at first, can usually be very easily differentiated by the absence of gonococci in the discharge and the almost immediate response to treatment when the cause is removed. Other forms of vaginitis, due to the exanthemata, cervical carcinoma, or simple cervicitis, can be eliminated by the history and findings in each case and the absence of gonococci. Treatment. Rest in bed and frequent douches of mild antiseptic solutions should be ordered. In the most acute stages, when the pain is severe, boracic acid douches at a temperature of 100 degrees to 110 degrees Fahrenheit under mild pressure are probably the most beneficial and soothing. These should be given frequently, every 2 or 3 hours if the discharge is profuse, and the utmost care should be taken in regard to asepsis. If, at the time of the examination, the lower portion of the vagina is found to be the part especially involved, care should be taken to insert the douche tip but 1 to 2 inches into the vagina and flush out only the lower portion. After the early acute stage is over, Lysol or bichloride of mercury, 1 in 15,000 to 10,000, can be substituted, and gradually a daily or twice daily installation of Prodergol, 4 to 10%, or Argyrol, 25%, can be made with a glass syringe, the douche preceding this treatment. Douches should be given sufficiently often to keep the vaginal outlet quite clean, and thus preventing a secondary vulvitis. Between treatments, absorbent vulva pads should be worn, and these changed often enough to ensure perfect cleanliness.